Imagine an immune system that is so profoundly confused that it wages two completely different cellular wars on two sides of the exact same physiological wall.
Yeah, it's a total paradox.
Right. On the outside, it attacks the tissue until it aggressively scars, like hardening and fusing completely shut. But on the inside, just millimeters away, an entirely different inflammatory cascade is causing the lining to just rapidly peel away and shed.
Which is incredibly painful.
Exactly. So today, we are taking a stack of really dense medical guidelines, textbook excerpts, and clinical studies to extract the most crucial insights for you about this highly specific, complex challenge.
It's a fascinating area of medicine.
It really is. Our mission today is figuring out how specialists actually manage the coexistence of severe vulval lichen sclerosus adhesions, or LS, and secondary desquamative inflammatory vaginitis, which is called DIV.
Right, and this specific dual diagnosis is, well, it's the absolute definition of diagnostic and surgical muddy waters.
Because you're dealing with two completely different problems at once.
Exactly. You have two distinct inflammatory conditions operating in the exact same general area, but they're affecting entirely different tissue types.
Wow.
Yeah, to solve the physical problems they cause, specialists basically have to act like firefighters. I mean, they have to put out two different types of chemical fires before they can even think about rebuilding the structure.
It sounds like a total masterclass in medical problem solving. But before we get into how a specialist actually fixes this, we really have to understand the specific chaos each condition creates on its own.
Right, you have to understand the fires first.
Let's start with the internal fire. Physiologically, what is happening with DIV?
So desquamative inflammatory vaginitis, or DIV, primarily affects perimenopausal white cis women. And the key thing to understand here is that it's an inflammatory reaction.
Not an infection.
Right, not an infection at all. The vaginal mucosal lining is basically desquamating, which is just the clinical term for shedding or peeling off at a highly abnormal rate.
And from what I read, the primary trigger is idiopathic, meaning the cause is unknown, right?
Yeah, exactly. But the clinical markers under microscope paint a very clear picture of a collapsed ecosystem.
Starting with the pH levels, I assume?
Spot on. A healthy vaginal environment is highly acidic, usually a pH between 3.8 and 4.5. And that acidity is maintained by lactobacilli, which are healthy bacteria that act as environmental guardians.
But in DIV, those guardians are just missing.
Completely absent. So the pH spikes above 5, and once it becomes that alkaline, opportunistic bacteria just thrive.
Which triggers a massive immune response.
Exactly. And that immune response is what doctors look for on a microscope slide. They look for a specific 1-to-1 ratio of inflammatory cells to squamous cells.
Let's break that down because I know it involves neutrophils and peribasal cells. What are those doing exactly?
Well, neutrophils are your immune system's first responders. When you see a massive influx of them, the body is basically flooding the area to fight a perceived threat.
Okay, and the peribasal cells?
Those are immature cells from deep down near the basement membrane. Normally, the surface is covered in mature, flat, squamous cells.
Wait, so if a slide shows a 1-to-1 ratio of those first responders to the deep tissue immature cells...
It means the entire mature surface layer has been completely stripped away.
Oh, wow. So the body is just exposing its raw, immature base layers.
Yeah, the shedding is that violent. And for the patient, it causes purulent discharge, irritation, and these spotted rashes called petechiae.
Okay, so that covers the internal fire, the DIV. But then we introduce the external fire, which is vulvar lichen sclerosus, or LS.
Right, and LS is a chronic, progressive inflammatory disease. But it affects the external skin, not the internal mucosa.
And it often presents in a very specific way, right?
Yeah, dermatologists often see it as a figure-of-8 white patch pattern around the vulvar and perianal areas.
And if left untreated, the inflammation just causes severe scarring.
It's a total loss of normal architecture. The body overproduces scar tissue, and the tissues can actually physically fuse together.
Which you call adhesions, right? Like the labia minora fuse together and the clitoral hood scars shut, which is phimosis.
Exactly. And crucially, the vaginal opening itself narrows significantly. We call that introital stenosis.
Okay, let's unpack this. It basically sounds like a house where the external doors have rusted shut and fused to the frame.
That's a really good way to visualize it.
Right, that's the LS. While inside the house, the wallpaper is actively peeling off the walls due to, like, intense humidity. That's the DIV.
Yes, and both are happening at the exact same time.
So if both are happening at once, where does a doctor even start? I mean, my first assumption would be to surgically open the fused doors so you can get inside to treat the peeling wallpaper.
And that assumption would be a trap.
Really? You can't just open the doors?
No, stepping into the operating room immediately is a huge clinical error. You can never perform surgery on actively inflamed LS tissue.
Oh, because of cobnerization. I was reading about this. The trauma of the surgery actually makes the scarring worse.
Exactly. The trauma of a scalpel induces more scarring and inflammation.
Mm.
The immune system is already hypersensitized.
So the body's fibroblasts basically go into absolute overdrive.
Yes. Instead of repairing a small cut, they overproduce collagen. The surgical trauma actively recruits the disease right back to the site of the injury.
Wow, so it heals the cut by fusing everything back together even tighter.
Right, which means the fire has to be completely extinguished first.
The principle of medical management first.
Exactly. Specialists use this robust, overlapping medical regimen. For the LS on the outside, they use ultra-potent topical corticosteroids.
Like clobetasol propionate, right, not just standard hydrocortisone.
Right, clobetasol is incredibly potent. It forcefully suppresses that localized immune attack. But for the DIV on the inside, the treatment is different.
Because it's mucosal tissue.
Exactly. So they typically use intravaginal clindamycin, which is an antibiotic, to reduce the abnormal bacteria, or an intravaginal hydrocortisone cream.
But wait, the notes from the Centers for Vulvovaginal Disorders mention something really fascinating here. They sometimes use a shotgun approach.
Yes, the compounded cream.
Right. Prescribing a compounded cream that mixes clindamycin, hydrocortisone, and estrogen all together in one dose. But isn't a shotgun approach usually frowned upon in medicine?
Well, what do you mean?
Like, aren't you supposed to change one variable at a time? Throwing everything at the wall to see what sticks seems a bit, imprecise.
Well, what's fascinating here is that the etiology of DIV is unknown. It could be related to declining estrogen, an exaggerated immune response, or abnormal flora.
So you kind of have to hit all three at once.
Exactly. It's incredibly pragmatic. The combined cream treats the bacterial component, the immune-mediated inflammation, and the estrogen improves the vaginal epithelial integrity.
It terraforms the ecosystem. The estrogen brings back the glycogen, which feeds the lactobacilli, which drops the pH back down.
You've got it. It's highly efficient for a patient suffering from overlapping conditions.
Okay, so you blanket the inside with the compound and suppress the outside with the clobetasol, but once the inflammation is finally in remission, you still have those fused doors.
Right. The structural damage remains. And that is when specialists can finally pick up the scalpel.
To release the adhesions.
Yes. Surgical options for releasing severe adhesions, which we call synechialysis, include a medium perineotomy, also called Fenton's procedure.
Or the use of a carbon dioxide laser, which is the approach I found really interesting in the notes.
Oh, the CO2 laser is highly favored here.
Yeah, so under general anesthesia, with a Foley catheter and rectal probe in place for safety, they use a handheld CO2 laser. When they stretch the vagina, the adhesions look like gray-white fiber bundles.
Right. The scar tissue is very distinct.
And then the surgeon uses short bursts of 12 watts to vaporize those bundles. Here's where it gets really interesting to me.
The 12-watt bursts.
Yeah. Using a laser in short 12-watt bursts sounds less like traditional surgery and more like a bomb technician carefully snipping specific wires to diffuse a structural collapse.
That is a perfect analogy. And the CO2 laser is preferred over traditional cautery, specifically because it minimizes damage to the surrounding fragile tissue.
Because traditional cautery uses conductive heat, right? Like a microscopic blowtorch.
Exactly, which causes thermal spread. It burns and damages the healthy tissue around the cut.
Which would be disastrous for a patient with a history of LS and cobnerization.
Right. Any ambient heat damage would trigger the scarring all over again. But the CO2 laser relies on light absorption by water molecules. It vaporizes the target cell instantly without heating the area around it.
Zero collateral damage. You sneak in, vaporize the blockade, and sneak out. But even with a perfect surgery, the post-op blueprint seems brutal.
The surgery just separates the tissues. The body's natural healing response is going to try and stick those raw edges right back together immediately.
So how do you prevent the refusion?
Immediate post-op care. Right after surgery, they fill the vagina with Silvadene or petrolatum to act as a physical barrier for the first 24 hours.
And the patient has to keep that up at home, right?
Yes, they are often instructed to apply petrolatum 3 times a day with an upward fingertip sweep.
Just manually keeping the labia separated. Wow. And then there's the dilator and medication regimen.
The rehabilitation is intense.
I read that in the first week, the patient uses 2 grams of vaginal estrogen nightly and begins using a small, rigid Syracuse dilator for 20 minutes a night.
Right, to mechanically maintain that physical space.
And then by week 2, they switch back to the topical steroids or calcineurin inhibitors like tacrolimus to keep the autoimmune response suppressed while healing.
Exactly. You have to quiet the fibroblasts while the tissue repairs itself in that open conformation.
So what does this all mean for the patient? Because this sounds incredibly demanding.
It is.
Like taking on a medical part-time job just to heal properly?
It absolutely is, which is why patient motivation and education are critical.
Mm.
Specialists have to counsel patients heavily. There is no cure for LS or DIV.
Wait, no cure at all?
No, only management. The ultimate goal is to transition the patient to a maintenance phase.
So using steroids 2 to 3 times a week forever.
Yes. Combined with dilator use or penetrative intercourse to maintain patency. It's a lifelong plan.
Which explains why this requires a highly specialized, multidisciplinary team. You need dermatologists, gynecologists, and pathologists all working together.
It really takes a village to support the patient through it.
So to recap all this for you listening, treating the coexistence of severe LS adhesions and DIV is basically a masterclass in patience and precision.
Oh, without a doubt.
It requires taming the local immune system with potent steroids and antibiotics, utilizing precision surgical techniques like those 12-watt CO2 lasers, and executing a rigorous post-operative regimen using estrogen, dilators, and physical barriers.
You know, if we connect this to the bigger picture, it really leaves you with something to mull over.
What's that?
Well, if the human immune system can become so localized and confused that it simultaneously causes the outer vulvar skin to scar and fuse shut,
LS.
while causing the intervaginal mucosa to inflame and shed, which is the DIV,
Right.
what does this tell us about the future of autoimmune therapies?
Oh, that is a great question.
Right. Instead of taking systemic pills that suppress the whole body's immune system just to fix a local problem, the future of medicine might look exactly like this.
Highly localized, micro-targeted treatments applied directly to the specific square inches of tissue that have gone rogue. That makes so much sense.
It's a completely different way to approach immune response.
It really is. Thank you so much for joining us on this deep dive into the clinical management of LS and DIV. We hope you're leaving with a much clearer understanding of this incredibly complex dual diagnosis. Keep questioning how things work, and we will catch you on the next deep dive.